Welcome everyone to our webinar this afternoon. This is a webinar entitled Focus on Essential Tremor. And essentially, this is the capstone event really of our events that we've scheduled to celebrate the 2023 National Essential Tremor Awareness Month. We have 3 presentations today, as opposed to the 2 that were originally advertised. The first will be by Dr. Tabish Saiffee, who is a consultant neurologist here in Queen's Square. We then have a presentation prepared by an occupational therapist here in Queen's Square, looking at how the occupational therapist has a role in the management of essential tremor. And then the final presentation will be by Professor Ludvic Zrinzo, looking at surgical treatment of essential tremor. Just as a bit of housekeeping, there is a chat function. So if you have any questions throughout the talks, please do put them into the chat area. And at the end, we should have some time for some Q&A. If you'd rather raise your hand at the end of the presentation during the Q&A, then you're more than welcome to do that as well. There's a raise hand function at the bottom of your screens. Just to say, the presentations are being recorded today. Please be aware if you're going to be sharing any specific details about your essential tremor. I should probably introduce myself. My name is Peter Sutton. I'm the operations manager for the Queen's Square Imaging Centre. As you may or may not be aware, we are the most recently launched MR-guided focused ultrasound service here in the UK. There are now 3 in England, and we are offering a rapid access service to patients who are seeking private treatment, but soon to hopefully treat some NHS patients as well. So without further ado, I'd just like to introduce Dr. Saiffee.
It's a real pleasure to talk to you today about essential tremor. I'm Dr. Tabish Saiffee. I'm a consultant neurologist at Queen's Square. I'm a movement disorder specialist and have a particular interest in tremor. In fact, my interest in tremor started during my PhD, where I undertook a 3-year research study looking at the causes of tremor in certain conditions and why they happen and what mechanisms in the brain drive that tremor. So today we're going to talk specifically about essential tremor. Essential tremor is a very common condition. It's a condition that probably affects about 2 or 3%, perhaps more. It varies a little bit depending on the studies you look at and the countries in which you look at those studies. But generally, a few percent of people, somewhere between 1 and 5%, perhaps about 2 or 3% of people seem to have essential tremor. It's a condition that causes a tremor or a shaking in the hands predominantly, but other body parts can certainly be affected, and we see tremor occurring in the legs, sometimes in the face, the jaw, the tongue, the voice, and the head as well. But often with essential tremor, the dominant tremor seems to be in the hands or in the upper limbs. It's often reasonably symmetrical, but some patients have tremor more notable on one side than the other. And I often find patients find that the shaking tends to be a little bit worse subjectively in the dominant hand, perhaps because they're more reliant on the dominant hand. It's a condition that tends to come on at all sorts of varying ages, and I see patients where it started in their teens or 20s. But as with age, the prevalence of tremor, or how common it is, seems to increase as we get older. And by the time we get into our 60s, 70s and beyond, it becomes a very common type of movement disorder. In fact, one of the commonest forms of movement disorder that any neurologist might see. So tremor can be very varied in terms of its severity. It can be quite mild. For some people, it may be more severe. And it can affect or interfere with certain activities of daily living, for example, writing or doing up buttons or holding a cup. It can also have profound implications for some people in social situations. So when people are meeting friends or family, they might feel less confident because of the tremor, which can have a significant effect or bearing on some people's social lives. So that's what essential tremor is and looks like, and many of us will be familiar with that. So what causes essential tremor in the first place? Well, in order to talk about that, I just want to take a quick step back and have a think about how we control our movement. So within the brain, right at the top of the brain, at the surface of the brain on one side, we tend to send a signal down, which travels down through the brain through what are called motor nerves or motor neurons, down through the stem of the brain or the brain stem to the spinal cord. And these connect with other motor nerves, which then travel through our body, perhaps through the limbs, to connect with the muscle, a bit like a wire down to the muscle and sending a signal to the muscle to move. Now, built into that downward or descending pathway signal is a subtle oscillation, and that's a normal part of movement physiology or movement control. So, for example, if I were to put my hands out, I would not have a very noticeable tremor, but if you put some very sensitive motion sensors on my hands, you'd be able to measure a very tiny, almost imperceptible tremor called a physiological tremor. And that's normal, and that's built into our normal everyday movements. Now, with essential tremor, it is essentially a network disorder. And that means there are certain nodes within the brain that work together and communicate together to alter that descending control and to modify it and to make it accurate, for example. With essential tremor, these nodes or networks seem to almost reverberate, or they communicate with each other and generate a much larger oscillation that comes down to our muscles with that motor control. So it develops a very large oscillatory movement that we then call tremor. And that is essentially what is happening in essential tremor. So we see areas like the motor cortex right at the surface of the brain, then very deep areas like the thalamus in the middle of the brain, then areas right at the bottom of the brain like the cerebellum and the brainstem that are all important within this network. Now, we might not see these lighting up on a normal MRI brain scan, but if we took large numbers of volunteers together with essential tremor and do specialist type of what's called functional imaging, we might see these networks lighting up. So what is driving that in the first place? Why is somebody developing a network disorder? Well, in essential tremor, it's quite common to see it occurring in other family members. So here's a little family tree with somebody down here being affected, but you can see shaded in black a number of other family members affected, siblings, parent and grandparents affected. And that's not uncommon in essential tremor. It's by no means essential, excuse the pun, but it is quite common. So there are clearly genetic predispositions, but there are environmental predispositions as well. And it seems to be an accumulation of perhaps both the genetic and the environmental factors that come together to then produce this network disorder within the brain that is essential tremor. Sometimes you might not see a family history, but it may be that there are genes that are passed down from one person to another that just slightly increase the chance. And if on top of that you put the environmental factors, then somebody generates or develops essential tremor. The brain is essentially a big electrical circuit, and there are nerve cells, perhaps hundreds of billions of them, all connecting, each one connecting with thousands of other nerve cells. So this big electrical circuit board seems to be the beginnings of the substrate of what causes essential tremor. These nerve cells communicate with each other. So here in this diagram, you can see nerve or neuron A at the top connecting with nerve or neuron B at the top of the diagram. And blown up a bit lower down here, you can see how these two nerve cells connect. And this is called a synapse. This is the typical way one nerve cell within the brain connects with another nerve cell. This first nerve cell or neuron releases chemicals, these little red dots, that pass through this very tiny junction across to the other nerve cell. And almost like a key and lock mechanism, this chemical binds to receptors. And these, what are called neurotransmitters, and this this junction between one nerve cell and the other seem to be an important part in the generation of abnormal circuitry. And in fact, this might be the very area where some of our medications seem to work for tremor by altering or affecting this neurotransmission from one nerve cell to another. So how do we diagnose? So if you were to come to me or to another movement disorder neurologist, and how would one go about making a diagnosis of essential tremor? Because in fact, there are a number of different causes for tremor, and essential tremor is by no means the only one. It's one of the most common causes, but there are others, and I'll come to some of those. But the way that we make that diagnosis is it starts with taking a history. So that means finding out how the tremor began. Did it come on suddenly, or did it come on gradually? Which body parts does it affect? And how does it affect the person? How does it affect you? Is it socially embarrassing? Is it functionally disabling? Does it affect handwriting? All the other things I've mentioned before. And that's very important in terms of determining what sort of treatments we might want to approach. We also ask about other factors like medications one is on, or other symptoms that may relate to the possibility of an alternative diagnosis to essential tremor. We then examine the patient. So that means having a look at the patient, having a look at the tremor itself. We might look to see if the tremor is at rest. So you can see this person's hands are at rest on a pillow. So none of the muscles are activated. They're all nice and relaxed. And if a tremor develops in this position, that's called a rest tremor. That's not very common for essential tremor, and that would usually make us think about other types of conditions. Sometimes Parkinson's disease can present with a tremor at rest in the hand, whilst we also then look at the tremor in certain positions or postures, and that's much more typically the sort of tremor we see in essential tremor. So with the hands outstretched and the hands shaking, for example, or the hands in movement. And so it's important for us to look at the tremor, but we will also examine other parts of the body, and we'll examine the face and the limbs, because this can give us clues as to the possibility of an alternative diagnosis. And I've mentioned Parkinson's disease as another common tremor disorder that can be determined during the history and the examination. Finally, for some patients, but not all, there are certain tests or investigations that are helpful. Now, these tests could include blood tests to look for conditions like thyroid disorders, which may generate tremor. And sometimes there are brain scans that need to be done, for example, an MRI scan, or certain scans that look at neurotransmitters in the brain, for example, dopamine, that may be abnormal in Parkinson's disease. So in a proportion of people, not everyone, certain investigations need to be undertaken. But in a number of people, a very clinical diagnosis, meaning the history and the examination, can suffice in that diagnosis. So when we look at essential tremor, what we often see is we see a shakiness of the hand. That might be borne out when somebody's asked to draw a spiral. You can see this, what's called Archimedes spiral on the right, is fairly nice and uninterrupted by tremulous movement, while the one here on the left is rather tremulous and occurred in a patient with essential tremor. We can go on to look at the tremor using certain measuring devices. So in your smartphone in front of you, you will have certain devices called accelerometers and other measuring devices that can pick up tremor. We can use these either on the phone itself. There are certain apps that can pick it up, or we can use accelerometers or gyroscopes to put onto the hand or the tremulous body part and actually measure the tremor. This is quite useful in research studies and is not so commonly used in everyday clinical diagnosis. So when we come to thinking about the diagnosis, I've put essential tremor here in the middle. It is certainly one of the commonest causes of tremor, but there are a number of others. This is by no means an exhaustive list of them, but it just gives a little bit of a flavor of some of the other possibilities. There are conditions like functional tremor or drug-induced tremor, sometimes knowing about which medication has been started and knowing that a tremor has come on soon after starting a medication is very indicative or suggestive that that medication might be involved in the generation of tremor. There are certain types of tablets or medications that are really classically associated with the onset of tremor. For example, lithium or sodium valproate and certain other medications. I talked about something called physiological tremor, which we all have as a normal part of movement. Enhanced physiological tremor is a type of tremor disorder that tends to come and go and is a very minor type of tremor that's usually triggered by an obvious precipitant that will then hopefully disappear once that precipitant is taken away. Again, there are some other forms of tremor, and I won't dwell too much on these, but I've mentioned some of them here, including Parkinsonian tremor. So when we come to thinking about treatment, we need to take a step back and again address the question that I posed in the first place of how this tremor is affecting somebody's everyday life. And the two main paradigms I mentioned were a functional disability, so meaning the tremor is interfering with your ability to undertake tasks such as using a mouse or a keyboard, writing, holding a cup or bringing a spoon to my mouth to eat. Or the tremor might be socially embarrassing. And this is often underappreciated. And a significant tremor in a body part can very much affect people's confidence, as I've mentioned before. So it's not so much the amplitude of the tremor or the size of the tremor that's important. It's the fact that that tremor is having an impact on you or I in one of those for one of those reasons. And so I've seen patients with much larger amplitude tremor who are not so particularly bothered by the tremor, while some patients with much milder forms of tremor, for them it can have a much more significant impact. And that is very important in helping to shape the decision on whether to try different treatments. So here in this slide, you can see a few different pictures. It's right on the bottom left. It shows a couple of things about sleep and other factors such as caffeine. Now, these are not causes for tremor, but I think of them as precipitants. So if somebody has essential tremor, there are certain things in their lifestyle which may at times make the tremor more obvious or more problematic. And that might be, for example, smoking or drinking a lot of caffeine or feeling very tired or underslept. So those lifestyle factors and addressing those lifestyle factors can be very helpful. There are medications and a number of medications, and many of you with essential tremor will have tried a tablet or medication. This could include things like beta blockers, propranolol, for example. Other things that are used include primidone, which is an anti-seizure medication originally, but is really much more commonly used now for tremor. There are yet other medications, for example, alprazolam, clonazepam, and topiramate. Each of these medications is generally taken on an everyday basis, although there are some examples where they can be taken as and when, which can be helpful for people who don't need tremor treatment on an everyday basis. The tablets all have potential side effects. There's nothing that comes risk-free. And what I generally do is start patients on very tiny, small doses and only very slowly and gradually build up the medications. If there are any problems or side effects that occur, we can always moderate the dose. So there's no one correct dose for everybody, and it's very much personalizing the approach to a given individual person. What I often find is much finer, when I mean finer, smaller amplitude types of tremor tend to respond better to some of the medications. Well, some people with very large amplitude tremors, whilst they might develop some benefit from the medications will never get rid of the tremor completely. I've put a picture of an injection here. This is botulinum toxin, Botox, something you're probably familiar with in the world of cosmetics or have heard about in the world of cosmetics. And this is a treatment that we sometimes use it only works for a few months, and it's injected into the muscles of the forearms or sometimes higher up in the arms to treat limb tremor. The therapeutic window, meaning the chance of having a good effect without side effects, is quite a narrow target because it can also cause a bit of weakness. So it is used in some people in the minority of times, but with some real problems potentially associated with it. It is, however, really helpful if you've got a tremor in the head, and I find lots of patients respond well to it in that situation for the head tremor and also for a voice tremor. Okay, moving on, there are some other things that one can do. So this is a picture of a weighted fork. So weighted implements like cutlery or crockery, such as a heavy cup, that limb weighting can dampen the tremor down for some people and can be a very useful thing to try. So it's certainly worth trying. Some people wear weighted wrist bracelets or, as I mentioned, weighted cutlery or crockery. So do try that to see if it helps dampen your tremor down. Certainly doesn't help for everyone. And I've had some patients where they find that it actually exacerbates or aggravates the tremor temporarily. There are also some devices coming out onto the market. Unfortunately, none of these has been particularly game-changing, and we don't have access to some of these here in the UK, but the ones that are available elsewhere in the world have shown some very mixed results, but certainly nothing that's going to completely eradicate much larger forms of tremor, unfortunately. But this is an evolving world. Right here in the center is a picture of a brain on an MRI scan, and I'm not going to talk too much about this because my colleague, Professor Zrinzo, will talk much more about this, but essentially affecting that network within the brain or disrupting that network that we saw right at the beginning is an extremely effective form of treatment for essential tremor, really the best treatment. But of course, it's not a small undertaking. And I'll let Professor Zrinzo talk much more about that later on. So I'm going to end there and just say thank you very much for listening. I'm very happy to take some questions. Perhaps that could be at the end after our next two presentations. Thank you.
Hi everyone, my name is Shauna Pavel and I'm an occupational therapist at Queen Square. Today I'm going to speak to you about our role as OTs in the management of essential tremor. So we know that 9 out of 10 patients with essential tremor report that it affects them in terms of their activities of daily living, so areas like self-care, leisure and work. And as occupational therapists, these really are our core areas of business. What we aim to do is to understand how the essential tremor is impacting on you as an individual in order to help you to participate more fully in your areas of occupation. The key strategies that we'll use will be mainly education, adaptive equipment, and strategy training. When we look at the ET Impact Survey from 2020, 92% of people reported that they weren't seeing anybody other than their neurologist or their GP to help them in the management of these daily challenges, which correlates to kind of this earlier stat that we looked at with 9 out of 10 people having these daily challenges. So I'd really advocate for getting yourself referred to an occupational therapist if you haven't done already. And again, if we look at some of the further breakdown of the survey results here, about 50% of people report that they need help with eating and drinking. Again, about 50% said it was affecting their working life. And about half of these respondents also said it was impacting the kind of social side of their lives as well, with nearly 43% reporting that they rarely go out, if ever. So I'm going to use some of those key areas to talk to you about in today's presentation. We also know that there are things that can trigger tremors or increase their severity. So fatigue, stress, kind of heightened emotions, or having low blood sugars. And some of those things are kind of easier to eliminate, such as removing caffeine or stimulants from your diet. But other factors can be more complex, like fatigue and stress management, and require some professional support in trying to identify ways to manage those in your day-to-day life. So stress management and relaxation techniques. Stressful events are a fact of life, and whilst we might not be able to kind of change your current situation, what we can do is help you to understand how stress manifests in the body, as well as how relaxation can manifest in the body as well. We can help you to identify what it is, the kind of factors that are at play causing you stress, be they kind of physical, emotional, or environmental factors, and try and take steps to manage the impact of these on terms of how they affect you day to day. We can help you to practice relaxation responses, so examples may be different breathing techniques, guided imagery, and meditation, and find the ones that suit best for you. Another area that we commonly help people with is fatigue or sleep management. And again, it's a very unique and subjective experience. And we may ask you to kind of keep fatigue diaries to really get to understand you and what you're doing day to day. We can think about the demands and resources available to you and the strategies that may be useful to help you to budget your energy more efficiently across the day. Trying to help you to understand good sleep health and hygiene, and thinking about techniques that work, whether the issue is about getting to sleep, staying asleep, or whether it's about rising too early. Fatigue, sleep, and relaxation management are all very much dependent on lifestyle modification and behaviour change, and they can be difficult interventions to embed change in and require professional support for you to move forwards. So we know that work was one of the big areas in the survey that was highlighted as being an area of difficulty for people with essential tremor. And vocational rehabilitation is an area that OTs can really help people with. And it's basically whatever helps someone with a health problem to stay at, return to, remain in, or exit work well. And OTs are a core member of the team when it comes to delivering vocational rehab. There are a number of government drivers and legislation that we use to help when we are recommending changes in someone's working role. So what we use is an understanding of an individual's medical conditions, so essential tremor in this case, analysis of your job demands, and trying to identify reasonable adjustments that allow you and support you to remain in work. We can help you in maximising employment opportunities by developing strategies that may prevent illness or injury in the workplace, and we very much work in partnership with employees, with employers, HR, and so on. So sleep, fatigue, stress management are all kind of bespoke programs or intervention that we can help with, as well as that more specialist area of vocational rehab. And when we think about kind of activities of daily living, there are more general strategies that we would use when we are looking at how somebody approaches a task. So their postural setup, thinking about how they're moving their arms in relation to their body and trying to keep it as close to your body as possible. Looking at how you can stabilize a key joint such as the wrists or elbows and surfaces. And thinking about how you might be using visual information when you're reaching. So there's some evidence that suggests that reaching from memory, for example, to your coffee canister, as opposed to really looking at where you're reaching to, can reduce the tremor amplitude, as well as the technique of limb cooling. So this is where you apply cooling garments to the periphery, so your limb, to try and reduce the impact of the tremor. And again, there's been some research to suggest that for up to 2 hours, people have noticed the effects of limb cooling in reducing the amplitude of their tremor. And people may use these techniques throughout activities to help them to manage the tremor. Of those early results in the survey, about 50% of people are reporting that they need help from someone else to eat or drink. And again, about 50% of people are reporting that their essential tremor is impacting their social life, with about 40% reporting that they rarely go out, if ever. And those two statistics kind of come together, I think, because an awful lot of what we do as humans involves going to meet others for meals or drinks or coffee, going to someone's birthday party. And so often as occupational therapists, we are asked to look at eating and drinking with somebody as almost their number one area of concern. So when it comes to eating and drinking, the key things that we hear in clinic are about these kind of performance issues around the speed that it's taken to eat the meal, the neatness that is kind of happening at mealtime, safety in terms of risk or injury, and also the aesthetics are important to people as to how the adaptations actually look and if there might be something that somebody is happy to use, for example, if they were going to a restaurant. So if we start at the top of the screen and start to move down, what you can see here is an example of cutlery that have got wider barrels on them. These barrels can have weights added to them, and that weight can dampen down the tremor amplitude. And the weights can be kind of ranging from lighter to kind of heavier, depending upon what you need. By adding the barrel as a slightly wider barrel as well, it can reduce the muscle recruitment required in your grasp pattern. And then that can also have an effect in terms of reducing the impact the tremor has. Moving that little bit further down, you can see some cutlery that's got kind of angles on them. What we're doing here is thinking about altering your movement pattern again. And again, we've got those kind of wider barrels available to us. So what this does is the fork is reducing the requirement in terms of the tilt when you're reaching your mouth. The knife shown is what we call a rocker knife, and it's reducing that kind of forward-backward movement where people often find that food is kind of moving off the plate for them because they can't control that cutting action. So the rocker allows you to stabilize and to kind of perform that action in a much more succinct way. Coming down to the bottom then, we've got a surround on the plate here. And this is a plate guard. And again, it's about kind of putting barriers in place to prevent those points where food are moving off of the plate. You've got a spoon at the bottom there with a spoon guard on as well. And again, the role here being about preventing excessive kind of spillage when you're moving towards your mouth, as well as these softer guards can help if there's a risk in terms of hitting yourself or kind of knocking your lip or teeth by providing a little bit of cushioning at that point as well. You may also think about spoons that have got just a slightly deeper gully to them, so you can allow a little bit of movement within the spoon and allow that to be absorbed in that way. And then if we look at the bottom far left, this product is called a meter eater. And it's designed, the hydraulics in the long grey arm that you can see are designed to absorb movement inefficiencies like tremor to allow people to perform the activity of eating again. So thinking about drinks then, for some people it's about being able to get their hand directly around the mug or cup. For others it's about being able to hold on to the handle. Where this is an issue for people, those kind of insulated mugs that are available are very helpful in preventing risks to hands in terms of burns or kind of being able to hold hot drinks. A lot of them come these days with lids available as well, again, kind of increasing the safety aspect and reducing the spillages that can happen when moving towards your mouth. So if we look down at the bottom, you can see an example here of a self-leveling or kind of rotating handle that allows movement within the movement to your mouth, and the cup will kind of self-level. Beside that, kind of similarly to the angled cutlery, there are angled cups available. Again, it's reducing that requirement of tilt that's required at that end point when reaching your mouth. And then finally, kind of moving across, you can see an example here of a straw with a clip, little green section. And these little clips can secure the straw directly to the side of the glass. So there's less movement when it finally kind of reaches up to your mouth. And again, it's reducing the distance traveled in your hand reaching towards your mouth with straws. There are also one-way straws that are available, so the liquid that is sucked up through the straw doesn't return back down again, just reducing that effort that's required in that task. I should say that the items shown are just an overview. There are a lot of products available and there are a lot of solutions out there, so it really is about understanding what it is that you kind of need particularly and the key areas of concern that you have. But today is just a flavour really. Tremor cancellation technology is an area that's very much emerging and developing kind of day by day. If you look at the market, there's a huge variety of products that are available, and it can feel a little bit overwhelming with where to start. So ultimately, there are kind of two branches, one being more task-specific products. So for example, cutlery that have tremor cancelling technology built in, or devices that are generally worn on the hand or wrist that are there to kind of overall improve hand function. To surmise, they are very expensive usually. Overall, they don't tend to fully correct the impact of tremor. And even when they do have an effect, they are more so on that kind of mild to moderate range of tremor where they tend to work. There are contraindications to some of these devices, particularly if you've got implanted devices such as DBS or pacemakers. And there are links on the screen here if you are interested in kind of looking at those areas more particularly. Just to give you a little bit of a taster of some of these products, what they may look like. On the top, you can see those devices that are more so aimed at general hand function, the first of which is worn directly on the hand, and the second is worn kind of more like a watch on the wrist. And then on the bottom, you can see an example of a tremor cancelling spoon. So generally, these devices are working by either stimulating the peripheral sensory nerves to try and influence incoming feedback to the movement mechanisms of when the tremor is occurring, or they're working by detecting the movement of the tremor, detecting the movement that you're trying to perform with your arm, and they try and combat that by kind of dampening down and reducing the tremor. So you're generally feeling a sense of resistance against movement. I should say that I'm not kind of associated with any of these products, nor am I promoting any of them. This is purely to just provide an overview of these devices today. Today I've kind of gone into eating and drinking more specifically, and I've talked to you about more tailorized programs like fatigue and stress management and the treatment of tremor triggers, as well as that kind of more bespoke area of vocational rehab. As occupational therapists, we really are kind of concerned with those areas of meaningful day-to-day life for the individual who's kind of sitting across from us in clinic. So I just wanted to show you some examples of different things that we may suggest in more of those areas of life. So if we think about kind of meal preparation, you can see some photos on the screen here of what we call no-cry safety gloves. And they are gloves that basically allow you to use knives and to use kind of sharper things like graters, and they prevent you from cutting yourself ultimately. They're machine washable, so fine from a meal point of view. They can also be really helpful in areas like where you're maybe doing some gardening and using gardening tools. And again, those kind of risks with the movement and tremors are impacting your safety. Handwriting is another big area that we're often asked to look at, and there's a whole range of different techniques and equipment that we can try with you to identify what's the best solution available for you. When we think about personal care, so kind of getting yourself washed and dressed, some of those tasks can be more difficult to complete. An example shown here is a nail clippers stabilized against the supporting surface, the table. So again, it's just modifying how you're completing that task to reduce the effort required in how you're using your hands and using the environment available to you to really maximize the stability within function. Down on the bottom, you can see someone chopping carrots, and they're using a chopping board with a pivot knife attached to it. So just at the very top, you can see that the knife has been secured on the board. So again, it's reducing that freedom and giving you a point of stability again at that point. The keyboards shown, so computer skills and kind of accessing technology, again, is a huge area that we think about. And it may be that we're kind of looking more so at the accessibility functions on the software that you're using, as well as looking at hardware like keyboards or the mouse. So the example shown here is an XL keyboard, so the keys are up to 4 times bigger in these situations, and that allows that kind of movement and tremor. It reduces that impact when it comes to kind of hitting the wrong keys, the kind of neighboring keys. And there are many, many other techniques available other than just this one. And then finally shown is a functional hand weight that some people like to trial if they find that kind of the weighted techniques in particular work best for them. They may be interested in using these kind of gloves more as a more general strategy. So finally, it's just to say thank you for listening to me. I hope you enjoy the rest of your webinar today, and I'm sorry I can't be there with you virtually. If anyone has any questions or anything they want to kind of reach out about, then please do get in touch with us. And then apart from that, just enjoy the rest of your day. Thank you.
my role today is to talk through the neurosurgical options for essential tremor, and it moves very nicely onto what's been described already by Dr. Saiffee. And the overview of what I'm going to talk about in the next quarter of an hour, I think we'll just discuss about what actually causes tremor. We've already had a bit of that from Dr. Saiffee, but it's important to understand how neurosurgery can help reduce tremor. And what procedures are available. And there are 4 main procedures, including radiofrequency ablation, gamma knife ablation, deep brain stimulation, and the newest kid on the block, focused ultrasound ablation. We'll talk about the risks of surgery. And as a patient, I often get the question, well, help me decide. First of all, should I have surgery for my tremor? And if so, which procedure should I have? And finally, at the end, we'll take some questions on all of that. So tremor is caused by an abnormal synchronization of the firing of these nerve cells of neurons across a neural circuit within the brain. And we've had this amply described by Dr. Saiffee before, but there's a really good example here of metronomes. And if you can see the metronomes and even hear them, we see that metronomes that are out of sync, if they're abnormally connected with each other, you can get this effect. And this is what happens in disorders that result in tremor. You have this abnormal firing of neurons together that drive the tremor within your hand, within your head, within your leg. And it's important to understand the genesis of tremor, because once we understand the mechanism, we can understand why neurosurgery might help. And when people think of neurosurgery, they often think of what we call structural neurosurgery, which is removing the tumor from the center of somebody's head, or a blood clot, or a tumor pressing on the outside of the brain, or in this case, another patient of mine who had a screwdriver embedded in their head that one had to remove. But what we're talking about today is functional neurosurgery, where there are circuits within the brain that are misbehaving, that are firing abnormally in synchronization. And what we want to do is to intervene to break that circuit. And Dr. Saiffee talked about nodes within the circuit, and the preferred node for surgical intervention for most forms of tremor is the motor thalamus, this part of the brain, deep within the brain, where we can affect this surgically to break this synchronization of tremor. So as we've heard, tremor is a symptom of many different diseases or disorders. Essential tremor is the commonest cause of tremor, but tremor-dominant Parkinson's disease is common too. And there are other reasons why we might develop tremors, including multiple sclerosis or other causes of brain injury. And as we've said, neurosurgery can help by breaking the tremor circuit. And the ultimate aims are, of course, to reduce the tremor. But we want to reduce the tremor to improve function. And we've heard about why tremor can affect function in the previous talk. And again, the ultimate aim is to restore independence and quality of life in people who suffer from tremor. So we've heard of the 4 different neurosurgical interventions that can break the tremor circuit. The oldest one is radiofrequency ablation. And we've had this modality since the 1940s, believe it or not. And what this involves is an operation on the brain where you make a small scalp incision, a small burr hole in the skull, and you physically place a probe deep within the brain, placing the tip of that probe very accurately within that tremor circuit, within the motor thalamus. And then we can pass an electrical current through the tip of that probe, which allows us to heat the tissues such that you damage or ablate or cook a small area of the brain around the tip of the probe, about a quarter of the size of my little fingernail. So it's a really tiny lesion, but very precisely placed to break the tremor network without affecting nearby circuits. The second modality that was introduced is gamma knife ablation, and this involves focusing gamma rays on the part of the thalamus. Each gamma ray has a very small amount of energy, but where they intersect causes a high dose of radiation that can cause damage to the tremor network. The advantage of this is that you don't need to shave the hair, you don't need to make any incisions. The disadvantage is that it takes quite a few weeks for the gamma radiation to cause the lesion, and therefore you have no feedback of whether you've reached the right target or not, which is very different to radiofrequency ablation, where you see the result immediately. Deep brain stimulation involves implanting a permanent electrode within the brain and connecting that with wires that pass underneath the scalp and underneath the skin to a pacemaker or battery that's usually implanted underneath the skin of the chest. This is a very effective way of treating tremor as well as other brain conditions, including Parkinson's disease and other motor symptoms. The advantage of this is that we can operate on both sides of the brain, and we can optimize the dose of electricity required to break that circuit without causing side effects. The downside is that you have to live with implantable hardware that can cause infection or can get broken, and often requires a lot more follow-up than an ablation procedure. And perhaps the most exciting part of this talk, as it's a relatively new procedure and really results from the combination of wonderful technologies of MRI scan and focused ultrasound, is focused ultrasound ablation. And much like the gamma knife, what we see here are multiple sources of ultrasound energy, where the energy is very low for each ultrasound beam, but where these ultrasound beams intersect, you can produce a high amount of energy that heats the tissues and can cause a lesion that can then treat tremor. Of course, visualizing the target is the very first step of any neurosurgical procedure. And funnily enough, if you can see the target, you're more likely to hit it. And I think we're very lucky at Queen Square that we've done a huge amount of research on optimizing the use of MRI so we can see what we're trying to hit. And most centers around the world use average coordinates when targeting the motor part of the thalamus. And although this works in many patients, it really is a best guess approach. And our philosophy here has been to do a lot of research into MR sequences. We use something called connectivity MR as well as structural MR to evaluate the different structures within the thalamus. And this allows us to tailor the surgery to the individual patient. And the advantage of this is that we can hit the target on the first time. We don't need to explore for the target nearby a best guess approach. Of course, this reduces the surgical time. It gives us greater efficacy of reducing the tremor and also comes with less risk. So here are a few examples of the different techniques. This is what a radiofrequency operation looks like. You can see in the video above that the tremor isn't too bad with the hand outstretched, but quite typical of essential tremor. As we bring the cup towards the mouth, you get a loss of control, and it's impossible to drink without spilling. Same goes with eating. And after we've made that very tiny ablation, you can see on the MRI in the bottom right-hand corner, this tiny white spot, which is the lesion. You get an incredible improvement in the tremor, and you can see that reflected in the quality of the handwriting here with before the intervention, trying to create those spirals that Dr. Saiffee was showing us before, and a vast improvement in that in the handwriting. The advantages of radiofrequency ablation are that it's quick, it's cheap, it's effective. You don't need to shave the hair. But the disadvantages are that this is an open operation. You do need to make an incision and a burr hole in the skull. The lesion is irreversible, just like every lesion. And that may not be a bad thing if the lesion is in the right place, but it can be a bad thing if the lesion is not in the right place, causing side effects. This does usually require 1 or 2 nights in hospital for the person to recover from the procedure before they go home. This is just another example of radiofrequency ablation and a different type of tremor. This is tremor because of a lesion in the brainstem. This is called Holmes tremor. So the tremor has certain characteristics which are a little bit different from essential tremor. But just to show the point, the tremor here is so bad that this lady can't get her pen to the paper. She really just wanted to improve, to be able to hold her grandson. She'd never been able to hold her grandson because of the severity of this tremor. And we were able to use high quality MRI to identify the sweet spot within the brain with really dramatic results. And you can see here the great quality and the improvement of the tremor. And on the right hand of the screen, you can see her attempt at handwriting at the top. This is a Maltese patient, and I'm originally from Malta, and she was quite happy to be a citizen of that country, as you can see with the handwriting below. So it's a very gratifying thing to do as a neurosurgeon. We've talked about gamma knife thalamotomy. The downside of this is that it can take many months to take effect. The upside is because you aren't getting immediate feedback, you can't really refine the surgery. That's a downside in the sense that you can't necessarily be as accurate as you may for other techniques where you can refine your targeting based on what you see immediately during the surgery. But it does mean you can do this under general anesthesia for people who can't tolerate local anesthetic, although that's very rare. The real advantage of gamma knife is that it can be done without stopping blood thinners. So some people have tremor, but also have a mechanical heart valve, for example, and it's very dangerous to stop blood thinners in them. This is a very small group of patients, and really I would reserve this treatment for very either extremely elderly or fragile people or people on blood thinners. It's definitely not my first port of call, but it's a backup procedure for patients who can't have any other sort of therapy. Deep brain stimulation came into vogue in the 1980s, 1990s, and as I said, involves implanting a permanent electrode within the brain connected to a pacemaker that's usually underneath the skin on the chest. The advantages here are early reversibility. In other words, if you don't like the effects of what you are doing, then you can change the electrical dose, the dose of electricity. You can improve side effects by changing where you place the electricity, because you have 4 little contacts, and nowadays 8 little contacts on the end of the electrode. So you can refine exactly where you use the high frequency electrical current to break the tremor circuit. And the real advantage of deep brain stimulation is it allows us to treat both sides of the body at the same time. The disadvantages are that you are implanting hardware, which means the wire and the battery itself, and therefore this is more prone to infection and can be prone to becoming damaged. It does need multiple visits to the hospital to program the device to find the right dose of electricity. In some patients, for some reason, the brain becomes tolerant to the electricity, and the tremor breaks through several years after the procedure, despite increasing the dose of electricity to the brain. So focused ultrasound, as I said before, is a new kid on the block. It really is a wonderful combination of different types of technology. I don't want to bore you with it, but it is a really exciting development in the field of tremor management. And getting through the skull was the real difficulty here, because when you pass ultrasound waves through the skull, they become unfocused, and it's difficult to focus those ultrasound beams into one spot. And what we see here is if you don't focus those beams properly, if you don't phase focus those beams, you get a spread of energy, and you don't really get enough energy in one spot to create a thermal lesion, a heat lesion. But in the early part of this century, the mathematics and the engineering was solved such that you can perform something called hydrophonic phasing, and that allows you to concentrate the energy in one particular spot to get a very discrete lesion, and to therefore control tremor without getting side effects. One of the caveats is that not everybody's skull is suitable to transmit this energy. As the energy passes through the skull, the bone can absorb some of the energy, and very rarely you can have people whose skull just doesn't transmit the energy sufficiently well. So one has to obtain a CT scan to make sure that the person is suitable for this. This seems to be a problem for some reason in the East, in Asian skeletons and Asian skulls, but in the UK, with the majority of the population being Caucasian, this seems to be less of a problem. This is an anatomical variation. Of course, there's no point focusing the energy without being able to see where to focus the energy, and therefore we marry this technology with MRI scans that allow us to visualize the target that we're intending to hit. We do need to shave the head completely, and that's because we can't have any air bubbles that would impede the movement of sound energy into the head. But there's no need to make any sort of scalp incision or any sort of burr hole, and of course the hair will grow back. And during the therapy, we pump cold water around the scalp, because some of the ultrasound waves leave their energy in the skull, and the skull can heat up a little bit during the therapy, and we need to cool this down during the sonications, during the energy delivery. The other beautiful trick that this technology allows us to do is it actually allows us to measure the temperature in real time, and we can use MRI to confirm that the temperature rises exactly where we want it to be. And here is an example of the quite incredible results that one can get on the tremor control with the spiral on the left and then the spiral on the right after therapy. So the patient experience with focused ultrasound, as I say, you need a total head shave, but you don't need any incisions. The procedure is performed under local anesthesia. That's just to allow us to fix this frame to the head in 4 little spots here. The procedure is uncomfortable. A lot of people say that it's not as bad as going to the dentist. It's not painful. You can get a bit of a roller coaster feeling, and particularly if you tend to suffer from seasickness, you can get a bit of nausea. And therefore, we give some medication up front, including painkillers, anti-nausea medication, and also anti-swelling medication to prevent side effects from swelling around the lesion that we make. The brilliant thing about focused ultrasound, it says day case procedure. You come in the morning of the procedure, and by lunchtime, you're ready to go home. So this is just a summary slide of the advantages and disadvantages of each procedure, with the radio frequency being the one that we've used for almost a century now, about 80 years. Gamma knife ablation being my least preferred option, except in patients who can't stop their blood thinners. Deep brain stimulation being my preferred option if patients want to have bilateral surgery at once, or if they have really dodgy balance issues. Whereas focused ultrasound is a real it's a real bonus if you want a quick and effective solution as a day case procedure without undergoing any sort of open surgery. So what are the risks of surgery? And the risks of all of these surgeries are actually very similar, because what we're doing is intervening in the same spot within the brain. Thankfully, the side effects that are commonest are usually transient, although there is a risk, as with everything in life, of permanent side effects. These permanent side effects tend to be mild. So up to 1 in 3 patients can experience problems with balance after surgery, especially if the balance is poor before surgery. And we advise using a walking aid like a stick or so for a week after the intervention. Speech can be a bit slurred. It sounds like you've had a glass or 2 of wine for a few days. But usually that improves as well. Altered sensation of the hand or lip is something we haven't seen very commonly. But if it's severe, it can affect function, because if you have a numb hand or a numb lip, then you can have drooling or clumsiness of the hand as a result, but that's not something we've experienced. The chances of severe side effects increase with bilateral surgery, and therefore we tend to start with unilateral surgery, especially since actually getting rid of tremor in the dominant hand, if you're right-handed, the right hand, if you're left-handed, the left hand, that provides 80% of the improvement in quality of life. And getting rid of tremor in the non-dominant hand can be useful and desirable in some people, but arguably doesn't give as much benefit as treating the dominant hand. As a result, ablation is always staged, by which we mean we would never perform ablation at the same time, but we would perform ablation usually to treat the dominant hand first off. And then after a few months interval, we can assess the situation. And we could offer bilateral surgery if the balance is perfect, but we would usually advise it to limit to unilateral if there's any problems of speech or balance. As I say, deep brain stimulation may be the way forward if bilateral surgery is required. So the question I often get at the end of informing patients is, well, should I have surgery? And if so, what procedure should I have? The first thing I say, well, is tremor interfering with your quality of life? And as Dr. Saiffee said before, sometimes we have patients with really quite significant tremor, but they cope with it very well and they can live with it and have a very full life and they're happy, in which case there's no point. But some other patients have very minimal tremor and it embarrasses them socially or prevents them from eating or drinking, takes the joy out of life. And in that case, perhaps you should consider it. Of course, you want to try non-surgical options first. And if you're getting good results with medication or with therapies, then you don't need to proceed to surgery. But ultimately, you need to be assessed by a skilled and experienced multidisciplinary team, including a neurologist, a neurosurgeon, therapists, specialist nurses. And then we can establish what the risks and benefits of surgery are for you as an individual patient. And this will allow you to have an informed decision. A very important point, I think, is we really want to tailor the approach to neurosurgery. This isn't a one-size-fits-all. We want to be able to provide the best therapy for the individual patient. And if you work in the center that has all 4 surgical procedures available, then you can choose the best tool for the job. Whereas if you only have one of these things available, if you only have focused ultrasound and can't offer the others, or if you only have deep brain stimulation, can't offer the others, well, of course, then you're going to be restricted in what you can offer individual patients. And then finally, this is a quality of life procedure. So the decision of whether to have surgery or not is a very individual one. So in summary, essential tremor is common and can cause significant loss of independence and quality of life. We really should be considering neurosurgery if quality of life and independence are reduced and they don't improve with non-surgical therapies. This multidisciplinary approach is really quite important. We've heard from a neurologist today and now a neurosurgeon, and hopefully our technical issues can be overcome so we can get an allied health professional, an OT, in as well. And I would say that the National Hospital at Queen Square currently is the only UK centre that can offer all 4 tremor procedures. We're also a pioneer in using MRI to visualise the tremor target, and we have a global reputation for both excellence and safety and efficacy. So I'm really giving a talk here on behalf of a wonderful and very large group of people, a functional neurosurgical unit, together with other people like Tabish Saiffee and Peter, who's head of operations here, and Jody, who's the CEO of the Queen Square Imaging Centre.